Hi, I'm Mike Duggan. I've been teaching restorative dentistry for over 32 years now and to over 6,000 dentists. This video shows how I do it. Real-time, mannequin-based, hands-on, point of view, and patient real. If you are a pre-dental student, an aspiring teacher, an international dentist, join me at Duggan Oral Design, dugganoraldesign.com. All right, so today we're going to be doing a lot like we did yesterday. We're just going to change the prep a little bit because we're going to restore the tooth with a different material. So we have to make sure we understand a little bit about the difference between the two materials and what that requires as far as the difference between the preps. But let's make sure we're on track as far as the amalgam preparations are concerned. What do you have that is any questions whatsoever about what we've been doing the last couple of days?
I had a question. For the amalgam preparations for the gingival box, do we place an axiopulpal bevel
I hope so.
in the amalgam as well? Yes.
There it is. Yep. Yeah. And you might ask, okay, should we for composite?
Oh, okay. Yeah, that's what I got confused because
Okay.
I thought that we do it in amalgam and we do it in amalgam, but we don't do it in composite.
I don't know, do we?
Then I don't know, doc.
I don't know either. As far, the reason for doing it in amalgam is to keep this stress from building up in the amalgam. And, that's what I was taught, whether that's really true or not, in terms of the physics of the situation, I don't know. But I would do a bevel for the composite anyway, just because we're used to seeing preps without sharp angles. Okay? So it doesn't look right. That's not a very good reason, but it doesn't look right without a bevel.
Yeah.
Okay, because we're just so used to having bevels and don't want to have sharp edges and so forth. When we start talking about crown preps where we're making the restorations indirectly, then the consequence of having sharp edges is very important, and we'll talk a lot about that in a couple of days.
Yes, sir.
Yeah, so I'd just put an axiopulpal bevel anywhere you feel like it.
How much should be the bevel?
How much? In terms of how wide should it be?
Or like what angle?
I'll make it kind of like this and about like that. So, if you're going to have an effect of getting rid of the sharp edge, a 45-degree angle would have the most effect. Okay? If it's steeper or shallower, it's still going to have more sharpness.
Okay.
And, if it's half a millimeter wide or something, I mean, it's possible that you have to extend gingivally so little to get gingival clearance. If your axial is only half a millimeter tall, well, you can't make much of a bevel, or your whole axial wall is just tilted. It's a different thing. So, just figure it out as you go through. But if you have a reasonably tall axial wall, the size of the bevel is not terribly important. But let's make sure that it's not an effectively sharp edge. For crown preps, we'll talk about what is sharp. Okay, I'll define that for you in a couple of days, because there's a very specific thing that we have to be concerned about with crown preps if we have a sharp edge. But we'll talk about exactly what the consequences are of that in indirect restorations. But for the amalgam or the composite, just make sure it doesn't look sharp, and then we're fine. Not a big deal. Okay. Anything else? Everybody figure out how to keep the burr vertical?
Getting better.
Yeah, remember, most of you, when you're leaning the burr, when it's not vertical, you're leaning the burr away from you. That's what everybody always does. Everybody wants to lean the burr away from them. Everybody does that. I do it. It's natural. Okay? So when you're looking this direction, you tend to lean the burr away from you. So how do you prevent that?
By looking in
two directions.
Yeah, look to see if you are leaning it away from you.
Okay.
Okay? So you might, peek around like that or use a mirror or whatever, and then oops, I'm leaning it away from me. So, everybody's gonna lean the burr away from them. The people that get in trouble are the ones that don't notice or don't check. If you do check, if you realize, okay, it's important that I check this angle here, and then you check it, you see, okay, now I'm gonna make it vertical, then everything's fine again. And once you allow yourself to do the prep with the burr leaning away from you too much, a lot of you have discovered already that there's some big consequences for that. Okay. So those are things that we just have to kind of keep track of as we go along. Which direction we look when we're doing the prep, so we see what we need to. Again, every step of every prep, there's something you must see. And of course, if you must see it, then you better see it. And the only way to see it is to make sure you, first of all, know that you have to see it, and then secondly, look in the right direction so you do see it. Then you're going to be on track. Then you're going to be doing all right. Okay, so we're learning that a little bit more all the time. So every class 2 prep we do, when working the box, for example, we look parallel to the contact, downward at a 45-degree angle. We see everything we need to. But how we do that depends upon what quadrant we're in. So yesterday we learned that in each of the 4 quadrants, it's a different approach to how to look parallel to the contact and downward at a 45-degree angle, and a different approach to how you look from the other side and see that you're keeping the burr vertical. So that needs to be practiced. In the upper arch, of course, it's really easy. We use the mirror on this side, we use the mirror on this side, and it's not a big deal. In the lower arch, again, as you discovered yesterday, there's a lot more moving around. Okay, ready to move on? Okay, so the nice thing is for today, when you do composite restoration, when you do a preparation for composite restoration, the prep is basically exactly like you were doing yesterday. Now, on the other hand, yesterday when we found our margins and we cut inward in a straight line, we adjusted that until we got to 90 degrees. Today we cut inward in a straight line, and if it's obtuse, we're happy. We just leave it like that. So we don't want a 90-degree exit angle for composite. We want a flared exit angle. Why is that?
But we don't need mechanical retention.
Well, the 90-degree exit angle doesn't give us mechanical retention. Occlusal convergence gives us mechanical retention for amalgam, and dovetails and retainer grooves give mechanical retention, but we do not need mechanical retention for composite. True. It could even be diverging occlusally. It would compromise the lifetime of the restoration if it does diverge occlusally because it's too big on the occlusal surface. It's subject to too much wear of the margins. They could get ditched and don't have to be replaced sooner. So I try to keep it small on the occlusal surface. And we keep it small on the occlusal surface by not diverging it, but by keeping it, fairly parallel or convergent like the amalgam. But the exit angles, that's a whole different thing from the convergence and divergence occlusally. So this is divergence and convergence occlusally. This is the exit angle, okay? So we know about how to tell an exit angle. We know what a 90-degree exit angle looks like. We don't want a 90-degree exit angle today. Why don't we? But what about if we just did the same preps we did yesterday and fill them with composite? Won't that work?
That will also work, but we are trying to be more conservative.
What do you mean work?
Sorry?
What do you mean work?
We want to conserve the cusp.
You said that it would work to fill an amalgam prep with composite. So by work you mean that the restoration would last its expected lifetime? 12 to 15 years for composite? I think it will if we have a 90-degree exit angle of the proximal walls. You have to think about that a little bit. Yeah, so we have to kind of figure out what's important. We have to get adhesion. Okay, again, so we don't have mechanical retention, we have to have adhesive retention. How do we get that?
And increase the surface area.
Okay, so by having a 90-degree exit angle and changing it to obtuse angle, it increases the surface area? It might. So if it increases the surface area by 5%, is that significant? Yeah.
We are
The,
preserving enamel. No?
okay, so it's preserving the enamel, but how does that have to do with adhesion?
The bonding with enamel is better than the bonding with dentine.
If that's true. So if we change the exit angle, we get 5% more enamel surface, then it increases the adhesion by 5%, but we want to increase the adhesion by 500%. So how do we get adhesion between composite and enamel? What were you taught in school?
By exposing the rod.
Okay, want to be a little more detailed than that?
We expose them, we can go through them, and like the bonding and
When the rods are irregular, it's easier for the composite to bond with it than when it's cut at 90 degrees.
Okay, so what
It's
is...
more beneficial for the composite to bond with the enamel rods that are cut irregular, in 70 and 90 degrees.
cut irregular?
Like they're non. It's easier to bond when it's obtuse, not 90 degrees.
Okay, so it's easier to bond to the enamel if it's on an obtuse angle, you get better adhesion, okay? And why? See, I'm being a child now. Why? And again, that's the way I want you to be in the course. If you're not sure of something, just ask why. And that's a real simple question, you know. When you were young, you were encouraged to ask why until you asked why too many times. And they say, yeah, shut up. No, now you ask why again. So, but I'll ask you why, I'll demonstrate it. So you say that we get better adhesion to enamel if it has an obtuse exit angle. And so why? What's the mechanism of adhesion between composite and enamel?
Bonding with
There are resin tags that are formed in the interface of enamel. So
irregular
mechanical
tubules, so
interlocking.
it's better to interlock with the
So when
Resin
we-
tags,
when we
interlocking.
When we etch the animal, like there are some
The enamel rods open
materials,
up.
like organic materials that they gonna wash away, and if you have like obtuse angle, we have more surface for bonding to go.
It's not more surface area, it's the actual nature of the surface. If you have an obtuse angle, the nature of the enamel surface on that wall is completely different. Okay? Now again, enamel is what we call anisotropic. It's not the same in all directions, right? And we know that because there's these enamel rods that go like this, right? So think of the enamel like in my Udemy course on composite dental bonding. You know, I'm explaining a little bit about adhesion to enamel to a more of a lay population. But I took a bunch of chopsticks and I rubber band them all together. So I had maybe 50 chopsticks. And the side of the chopsticks, they're all pretty tight together. But if you look at the end, there are these spaces. Okay? That's what we need to be thinking about in terms of enamel. So with a 90-degree exit angle, like this, that surface is comprised of the side of the enamel rods. So the enamel rods are running like this, so that's the side of the enamel rods or the side of the chopsticks, whatever you want to think about. But if we were to make an obtuse exit angle, then we have something a little bit different happening. So let's say we make an obtuse exit angle like this. Then, on that surface, we expose the end of the enamel rods. So we cut across the end of the enamel rods. That's how we get adhesion. So it's not the surface area, it's the nature of the surface. If on that surface we've exposed the end of the enamel rods, we can get good adhesion because again, those resin tags and etching out those little spaces and so forth, all that happens on the end of the enamel rods. Okay, so anytime we get an obtuse angle, we have a good surface for bonding adhesively. So that's what we're looking for. So in each of these preps that we've done so far, we just will stop before we get to 90 degrees. We won't adjust it until it's 90 degrees. We'll cut straight in, we'll get an obtuse angle like we've been getting with the amalgam prep, but we won't change it like we do for amalgam. We're just going to leave it obtuse. Now don't make it too obtuse. If it's too obtuse, then we don't have an axial wall. The axial wall gets really, really small. So we don't want to make it too obtuse. But, you know, if it's visibly different from 90 degrees, we're in pretty good shape. Okay, so that's really the crux of the matter, okay? For amalgam, we want to have a 90-degree bulk at the margins, so we want to have a 90-degree exit angle, so we're not undermining the enamel, but we have a good bulk of amalgam at the margins so it doesn't fracture. For composite, we can have a smaller angle of composite at the margins, but it has to be adhesively bonded so it doesn't fracture. Okay, but it can be adhesively bonded because it's obtuse. Okay? All right, so what about the width of the isthmus? So we're going to talk about changes that we might make in the preps that we've been doing yesterday and the day before that would be suitable for composite restoration. So does the isthmus have to be as wide as it was for amalgam?
No.
Okay, how wide does it need to be?
It still needs to cover the caries.
Okay, we have to make sure that we remove the caries. And we have to see that we've removed the caries. So if it's too narrow, it's pretty hard to see what we've got. Now, of course, the composite, the prep can be very, very small and we can still fill it. Even if it's just 1/10 of a millimeter wide, we can still fill it, it's just a sealant. Okay? But with these preps, with the conventional design where we're having to go pulpily into the DEJ, put the DEJ back on here again. So if we have a prep that's pulpily into the DEJ is visible on the facial angle walls of the isthmus. So we see the DEJ on these walls. If the pulpal floor is indented, then we see the DEJ on those two walls, but we have to be able to see in there. So if we can see the DEJ and we see that it's not stained, we don't have decay migrating along the DEJ, then we've done our job and we're okay. So it has to be wide enough for us to see what's going on. Now, for amalgam, it has to be wide enough so we can condense, and that's at least 1 millimeter wide, but for composite, it could be more narrow. And we can still see what we're doing. We can see what we've done. We can see that decay is gone. So a little more narrow. Basically make it about the size of the burr. So 330 burr, make it that size, one time through and you're done. You don't have to be polishing it and smoothing it and stuff like that. Just cut through the center groove, look in the right direction so you know exactly where you are the first time through. And when you go through the first time, you're done. Okay, so a little more narrow there. The distal wall, what do you think about the location of the distal wall in this particular case? Or the location of the mesi wall in this particular case? Where should the location be? Should the location of that wall be in a different place comparing composite to amalgam?
In amalgam, we do divergent distal wall, but this could be straight or
You mean vertical?
vertical.
We still don't want to be undermining the enamel on the marginal ridge. So vertical is risky, so we'll lean it still the same way. Again, that's to protect the marginal ridge. You know, maybe we don't get good adhesion in that area with composite. You know, a lot of the restorations that dentists do in composite, they don't do it in a way that they get good adhesion. It's ironic in a sense. Excuse me. Because, you know, we have the ability to get adhesion and, you know, we do the preps because we assume that we get good adhesion, but if you do the restoration in a way that doesn't actually give you good adhesion, that's a problem. So again, sometimes dentists get careless about how they actually do the restoration. If they etch it and dry it and so forth, and then maybe they even prime it or put some bonding agent on, and then the patient swallows and it gets contaminated with saliva, and then they just blow it off and then put the composite in, they've got a failed restoration. It's just that simple. So when a lot of dentists don't get good isolation, especially at the gingival margin, that gets to be a real problem. Isolating the gingival margin is challenging. It's easy if you use a rubber dam, it's challenging in any other way of isolation. So any area where you're not getting good isolation, you're liable not to get good adhesive bonding. So knowing how we get good adhesive bonding is great, that's a wonderful thing. And being able to get good adhesive bonding is also a wonderful thing, but if we don't get it, being able to get it is one thing, getting it's another thing. So if we're careless about it, that's a problem. But, we can try to get good adhesive bonding as much as we can to this wall, and we won't have any trouble with that particularly. But the location of that wall is positioned more because of the fact that we want to get beyond the pit to remove the decay. We don't want to weaken the margin ridge any more than we need to, but we have to get beyond the pit to remove the decay. Same thing over here. We have to get beyond the central pit to remove the decay. We don't want to weaken the oblique ridge. So basically, whether it's composite or amalgam, we're going to put the wall in the same place. In either case, we want to have the pulpal floor just indent. So then the height of this wall is going to be the same, 1.5 millimeters, whether it's composite or amalgam. So a lot of that's basically the same thing. How about a dovetail? Do you think we should make a dovetail?
No.
What's the purpose of the dovetail?
Mechanical retention for amalgam.
Retention.
Mechanical retention, that's one purpose. What's the other purpose?
Preserve the margin ridge.
So that the height is 1.5 inside the groove.
Ah, so you're missing a pretty major point.
So the stability doesn't move around.
No. There are two purposes for the dovetail. One is mechanical retention, the other is,
Extending into the groove
why would we want to extend into the groove?
to make sure that the minimum height is 1.5.
So you're still thinking about it mechanically.
To include the decay.
We want to remove the decay, right? Two purposes for making a dovetail. The reason it always goes facially is because that's where the groove tends to be and that's where the decay tends to be. So we extend there to remove the decay. And also, as long as it's mechanically significant, we make sure it's wider facially than the isthmus for amalgam. For composite, we don't have to have the mechanical retention, but we still have to remove the decay.
Okay.
Okay? So your dovetail is going to be, could be a little smaller, but basically you're going to still make a dovetail. Keep it subtle. If you're doing a prep on a typodont, keep it subtle, but make a dovetail shape there. If it's in the patient, of course, you do what the patient needs, whatever it is. Depending upon how far the decay goes up that facial groove, we're going to extend out that facial groove to take care of the decay. All right, what about the axial? So far we have a slightly narrower isthmus, obtuse exit angles, the same basic wall position here and the wall height over here, and similar dovetail. But what about the axial wall position? Why did we position the axial wall where we did for the amalgam prep? Once we get beyond the DEJ, and we can see the DEJ on the facial and lingual proximal walls and on the gingival floor, then we can evaluate whether there's any remaining decay migrating along the DEJ in any of those areas. But we went a little bit deeper than we needed to for just the evaluation process in the amalgam prep because we needed to have some dentin on the facial lingual walls that was enough so that we could put retainer grooves in, right? For composite, well, we don't need retentive grooves, so we're going to get a little bit less deep axially, a couple tenths of a millimeter less deep. We're going to have defined but rounded internal line angles. Like we've done for amalgam, we want to get really well-defined internal line angles with the burr. And then, of course, for amalgam, we sharpen them and make them really square and put in retentive grooves. For composite, obviously, we don't need retentive grooves. So a little bit less deep axially, a couple tenths of a millimeter, nice rounded internal line angles, that's all we need to do. Okay, what about the gingival floor? How far do we need to go gingivally for a composite compared to amalgam?
So where we can see the gingival clearance.
Why do we need gingival clearance?
So that we can place the band and wedge and contour it.
You can put a matrix band in there without any gingival clearance at all. Okay, you just have to sort of wedge the teeth apart a little bit, slide it in, so forth. But why do we really need gingival clearance? You're getting down to some basics now, huh?
Overhang, so that the restoration does not overhang.
Okay, so no matter how much clearance we have, when we condense the material in there, whether it's amalgam or composite, we will have an overhang. And even if there's gingival clearance, there's going to be an overhang.
To get the detail.
Okay, let's get back to that in a second. But of course, we have to remove the overhang. We can't remove the overhang if we can't get an instrument in there to cut the overhang away. So you have to have enough gingival clearance so we can get an instrument in there and cut off the gingival overhang, whether it's amalgam or composite. Okay? Also, this is what I was waiting for you guys to get to. So the decay process is something like this. So there's the decay. So what if we go a little bit less deep gingivally? We talk about 1/2 millimeter gingival clearance. What if we get a 1/4 of a millimeter gingival clearance? So if we get 0.25 millimeters gingival clearance right here, what's the problem with that?
We are not removing enough decay and it might lead to recurrent.
Well, there is decay still there.
Still there.
If it doesn't, it's not that it might lead to recurrent decay. There's already recurrent decay.
Yeah.
There's a recurrent decay when the patient drives home. It's already started. All right. So for an amalgam restoration or preparation, if we go gingivally until we get 1/2 millimeter clearance, or let's say we go gingivally until we get 0.25 millimeters clearance for amalgam. Obviously, if we're going gingivally until we get 0.25 millimeters clearance for composite, it's the same thing. We're doing the prep. Okay? So if we only get 0.25 millimeters clearance, there will still be decay there. How will we recognize that decay in the patient's mouth? We'll look down the box and we'll see a white, decalcified, flaky, opaque area at the margin that we can take and explore and just sort of flake it away. Okay? That's the residual decalcification in the enamel at the gingival margin. So clearly we don't want to leave that there. So for amalgam, we extend gingivally a little bit more until we get 0.5 millimeters clearance, then typically the decay would be gone. We angle it gingivally, get rid of the undermined enamel, and then we're really happy with the way we did the amalgam prep with composite. If we stop with only 0.25 millimeters clearance, we have an alternative. We could get rid of that decay at the margin in another way. How could we do that? Okay, and yesterday we talked about the difference between an angled shoulder, an angled floor, and a bevel. Now if we make a bevel, see here's the decay, this little red part right here. What if I make a bevel like this? Now I have a gingival bevel, so I went less deep gingivally, And then I said, okay, there's still some decay there, so I'm just going to bevel the decay away. So I end up with the same clearance, 0.5 millimeters at the margin, but I have a gingival bevel in this case for composite. Well, that's pretty cool. So what do you think's cool about having a gingival bevel? Getting rid of the decay in an easier way. If I understand gingivally and just bevel off the excess decay at the margin, that's pretty easy, that's pretty cool. But there's another advantage to placing that gingival bevel, a really important advantage.
Better adaptation of the composite.
Well, not so much adaptation. For gold, we talk about beveling so that we get a well-adapted margin. But for composite, the adaptation of the margin is not as important as the adhesion at the margin. Okay? And so we talked about the mechanism of adhesion. The enamel rods in this area are going like this. So the bevel exposes the end of the enamel rods so that we can get adhesion. Okay? If we just angle the floor so the floor is like an amalgam prep and it's parallel to the enamel rods, we can't get good adhesion. But if we bevel it, expose the end of the enamel rods in that surface, now we get good adhesion. That's the difference between a 15-year Class 2 composite and a 5-year Class 2 composite. Gingival bevel. So that's where we're likely to get failure. Okay, you can imagine the plaque accumulation in that area is much higher than any other place around the prep, around the restoration, so we're particularly careful about that. So for composite, we don't go as deep gingivally with our box, but then we bevel the margin so we get 0.5 millimeter clearance, the same way we do for amalgam. We get good adhesion at the margin, we have enough clearance so we can use an instrument and cut away the overhang. And of course, when we have more clearance in that area for the patient, they're more likely to be able to keep the plaque level down at those margins, spatially and lingually and gingivally, and have a longer lived restoration. Okay? So there's not a whole lot of difference between the amalgam prep and the composite prep, but the differences are really important. The differences are determined by the fact that we need to get adhesion and we can get adhesion. And we need to be making sure that in areas where there's a possibility of recurrent decay that we absolutely get good adhesion at the margins. Okay? So amalgam, as you know, is much more resistive to recurrent decay than composite is. Composite's only good at it if we have a good bond at the margin. Okay, now, most dentists think that with composite, since it's adhesive, they can do any prep they want. And they can leave undermined enamel. Now that's kind of interesting. So we talked how important undermined enamel is with amalgam. So, are you thinking that if we have undermined enamel in our prep, that it's okay because we have good adhesive bonding with composite? Assuming you actually get good adhesive bonding? Most dentists do. And all of those, every one of those, most are wrong. And we have to figure out why. So we know a little bit about adhesive bonding now, but let's take a look at what happens. What happens if we have a prep, not just 90 degrees, what happens if we have a prep that is acute angle like this? We get an acute angle and the dentist says, okay, that's all right because I can get good adhesive bonding in that area. Okay, well, let's figure that out. So the enamel rods run like this. So the inside wall of that prep exposes the end of the enamel rods. That's pretty cool. So again, if the dentist uses all the procedures that we need to use for getting good adhesive bonding, etching and rinsing and bonding agent, primer, whatever, they should be able to get a good adhesive bond to the inside surface of that undermined enamel. Okay, does that mean we're okay? Why not?
Because they are not supported by dentine and they'll break.
Why will it break? They're glued in by the composite.
It might still break
And where will it break?
at the edge,
Oh, edge of what?
the, the point where,
They won't be able to bear the stresses.
yeah.
Okay, so this area here, this is all undermined enamel, right? So you're saying that undermined enamel will break off? It'll break off before the patient gets in their car. So it's not just a matter of stresses necessarily. So as we fill this prep, as it is here, as we fill it with composite, so we fill it, and then what do? We put the composite in, we do all the etching and prepare the surface and so forth. We put the composite in, then what do? We light cure it. What happens when you light cure composite?
Shrink.
It shrinks, big time. And that can have huge impacts. In fact, I'll tell you about a patient that I actually had when I was a student that I learned a lot from. I learned how much the tooth can actually distort in shape when you cure composite, and the composite shrinks, and it can actually distort the shape of the tooth and caused her a lot of pain for months until I got the composite back out again. It's very interesting. Anyway, it's a story for another day. But the shrinkage is hugely important. So if we fill this whole area with composite and we shrink it and it pulls this way a little bit, it's going to, the undermined enamel is going to stick to the composite, but it's going to fracture right here. It's going to separate. The undermined enamel is going to pull away from the enamel and the rest of it. It's going to open up that little gap. And that little gap, of course, is where we're going to get recurrent decay. It's recurrent decay not at the actual margin, but we're actually creating a new margin of the prep in effect. So when you think about that a little bit, it kind of makes sense, but a lot of dentists prefer not to think about that. They prefer to think they can be very careless about the prep and just fill everything with composite and glue it all together and everything will be fine. Well, not so much. Again, we have the idea from experience now that the composite restorations aren't going to last all that many years. And this is one of the reasons why. And this is one of the reasons why down here, okay? And just getting good isolation is another reason why. There's a lot of reasons why composite restorations just don't last all that long. They should be, and they can be made to last, a reasonable length of time. 15 years is reasonable. It's not like 50, but it's still reasonable. So if you have a reason why you want to have a colored restoration, and if it lasts for 15 years, that's a pretty good service. Why do you want to have a tooth colored restoration?
Aesthetic purposes? Aesthetic purposes?
And tell me about aesthetic purposes. What does that mean?
So it matches with the remaining teeth shade, and like you don't discover it right away. That is.
Who doesn't?
Whoever is looking at the person.
Whoever's looking at you. Ah, okay. So there's other people out there somewhere, and they're looking at you, right? You want them to think you're good-looking and natural and organic and all that kind of stuff, right? Okay, so you've been doing preps on the upper arch. So some of the preps that you've been doing with, for amalgam, when you overextend facially a lot, there's going to be a lot of amalgam visible. But if you have a class 2 amalgam done ideally, without any more clearance than you really need to get, and if it's in the upper arch, who's going to see it?
It's you.
Whoever's watching you sleep at night. Okay? Or if you're up on a stage singing, the camera's shooting up like this. I love these singing shows on TV. And so I'm always looking for the teeth, looking to see if they have fillings and so forth. But it is surprising, all these competitive shows, they have people that are just people off the streets pretty much that are really good singers. And the first couple of things when they do the auditions and so forth, you might catch the sight of some fillings, but by the time they've gone through a bunch of shows and they're doing better and better, those amalgam fillings just sort of go away. Now they're getting composite fillings in and getting them all replaced and so forth. One guy got teeth replaced and, this kind of thing. But, if you're singing on a stage, that's a whole different thing. I would probably, go through and get, especially if I were a successful singer, if I were really good and making a lot of money at it, I'd probably get my teeth fixed up really nice, stuff like that. But, most people just, you don't know that anybody has a restoration. Tomorrow and the next day, we'll talk about gold crowns that you can get that nobody knows are there. Okay. Under most circumstances, just conversationally, nobody knows that they're there. Okay, so composite is, don't get me wrong, composite as a restorative material is one of the biggest things that ever happened to dentistry. The biggest thing may have been amalgam, 100 years ago or more, but composite has changed dentistry significantly. Okay. Now, can you think of ways that composite has really changed the way dentistry is done? One way is, of course, doing direct restorations like we've been talking about, and doing them so they're tooth colored and so forth.
Conserving the tooth structure.
Okay, well, that's always nice, but, in terms of your appearance, doesn't really matter. If you can preserve tooth structure, it might. Composite needs you to preserve tooth structure. Okay, amalgam, you can cut half a tooth away and restore it with amalgam, and you're fine. Composite needs to be smaller. You need to not be doing too big a composite restoration, where things get compromised pretty fast. But let's think about indirect restorations. So what has adhesive dentistry done for indirect restorations? Indirect adhesive dentistry is composites. All this technology that we were talking about, and we'll talk about it more as we go along. But the adhesive dentistry has changed the world of indirect restorations. In what way?
Mineralization.
Hmm?
Mineralization. It aids in mineralization.
No, I'm talking about indirect restorations now. Crown and bridge.
Convenience.
Huh?
Convenience, single appointment.
Single.
Yeah.
Single appointment. Okay, how do we do a single appointment crown?
Yeah, with composite we can do inlays or things like that under single appointment.
Okay,
We
you can do
do
composite.
restorations that would require inlay, rather we can do
Yeah,
it with
if your dentist is really into it, you could do a lab, or not chairside necessarily, but a in the office fabricated composite inlay and cement it in. Okay, most dentists aren't going to do anything like that these days, but that was something that was popular some time ago. But let's talk about crown and bridge. How's that changed since we started using adhesive dentistry?
Better retention.
They knew well.
Retention in what way?
No, sorry, not retention, but better mechanical interlocking between the tooth material, enamel, and the cement peel. Because the cement, it adheres to the enamel as well and to the tooth material as well. Some cements.
Oh, the enamel is the tooth material.
Yes, the crown material.
Okay, what crown material?
We have
basically lithium disilicate based materials. We can use silane coupling agents and bond to the structures.
Okay, so you were talking about one appointment crowns. So CAD/CAM would not exist without adhesive cements. Okay, and adhesive cements wouldn't exist without the development of the composite resin technology. Okay, so everything that we've talked about, makes doing nice little class 2 composites doable, but also makes ceramic crowns doable. Okay, we had all ceramic crowns, almost 100 years ago, like in the 1930s and 40s. I'm not sure exactly what the dates were in there, but certainly before the 50s, we had all ceramic crowns, porcelain. The name escapes me right now, but all porcelain crowns that we had back then. There was a certain name for them. We don't use that name much anymore. But wait a minute. We're doing all ceramic crowns now. And back in the 1940s, we didn't have adhesive cements, did we? So the only cement we had in the 1940s was like zinc phosphate. So doing an all ceramic crown or an all porcelain crown on a tooth in 1940 with zinc phosphate, we didn't have the adhesion and we didn't have the strengthening due of the crown due to that adhesion, so the chances are that the porcelain would break at some point. So the breakage was pretty high. So that's why they invented PFMs, which we'll talk about next week. Ceramo metal crowns were invented because all ceramic crowns weren't working very well. But now they work again. Okay? They never did work, but now they do work. All ceramic crowns do work because we have the adhesive technology that allows us to cement the porcelain to the tooth structure. So we can cement porcelain to dentin. Okay? So that's pretty sophisticated technology, but it's not technology that was developed by dentists. And I don't know who developed it originally, but certainly shatterproof windows in cars were invented long before we had adhesive dentistry. And you're putting a layer of plastic inside glass, so you're basically bonding plastic to glass for shatterproof windshields and so forth. That saved a lot of lives. Okay, well, that's the same technology that we're using in dentistry. We're gluing something very organic to something very inorganic. And how to do that took a long time to develop. Anyway, that technology has made a huge difference in terms of how we do dentistry, as long as that technology is actually used. The manufacturing companies say, okay, well, here's this technology, and so there's these 3 steps that you have to do, and then you can get a good bond between the crown and the tooth. But here's another material that we have that you can do it in 1 step. And then the dentist says, okay, 1 step, I'm all for it, I want that. So the manufacturer doesn't say, well, it's only 1 step, but it compromises the results. It's not going to bond as well, and it might fail later on and so forth, and you have to be more careful and isolate the area really well. And I know that. I learned that myself the hard way because, I had a couple of porcelain onlays that were cemented in using, they were CAD-CAM onlays. They were cemented in using an adhesive cement, but not using all the steps of the technology that we have available to us. It was an abbreviated 1-step cementation process that was sold by the company that made the CAD-CAM machine. And both of them fell out. One of them fell out in a week. So the dentist re-cemented it, or actually cut another one. It was CAD-CAM, cut another one and cemented that one. And it stayed in for a longer period of time, but it had an open margin, so it's not there anymore. And the other one stayed in about 5 or 6 years, and then it fell out. Okay? So again, the technology is wonderful if we use it. CAD-CAM technology is wonderful. Well, why is it wonderful? What's the advantage of CAD-CAM technology?
CAD-CAM technology, we can make a lot of things with it, like we can make crowns, bridges, and we can scan for dentures as well.
Okay.
For occlusion line cards and other cases. And same day we have the ability to design the crowns and mill them out the same day, fabricate them.
Okay, so the big advantage is we can make the crown in the same day.
Same day.
Okay. Now there's other more sophisticated things like full mouth reconstructions, and it makes those things a lot easier. But just doing a single crown, we can cut it out in the back room and then cement it the same day. So it's a 1-appointment crown, and that's very appealing.
That's all.
Who is it most appealing to?
Patients.
And which patients?
Patients who have a very busy schedule.
Yeah.
Patients have really busy schedule. In Newport Beach, it's very appealing. Okay, these guys are making a couple $1,000s an hour. Okay, you don't want to take an extra hour. You're losing some big money. Okay, in towns where the average person is a blue-collar worker, and maybe they're laid off, maybe they're out of a job, maybe they're working from home, or who knows what. It might not be so important. But here's the ironic thing. If you do a CAD-CAM technology, you tell the patient that it's one appointment, they go, oh, right, that's great. I only have to come in this one time and I get it done. And then you use an adhesive technology that's not really complete, and you don't do it very well, and it falls out in a week. They're back anyway. What happened to that one appointment crown? Now it's a 2-appointment crown. And on top of that is that you've subjected the patient to the experience of the crown falling out. They don't like that. This $2,000 an hour guy might have fallen out when he's giving a presentation in front of, all kinds of people. So again, the technology is only as good as we take responsibility for using it well. CAD/CAM is a fabulous thing. There's no denying it whatsoever. Adhesive dentistry is fabulous. No denying it whatsoever. But again, it has to be used in an appropriate way for each individual patient. We don't treat every patient the same way. There's no one solution for every patient, for every situation, every patient's mouth. Okay. Yeah, certainly if we're going to do CAD/CAM, we need to be doing it well. Okay? So I would never use one of those one-step cements to cement a crown that I made by CAD/CAM. Also, you realize that, CAD/CAM, you cut the crown out of a block of ceramic. That block of ceramic is probably one shade throughout the entire block. Okay? You can get shaded ones that have different shades in different places and cut the crown out in different places. Those blocks start to get pretty damn expensive. It's a problem. But if you're doing one shade throughout the whole block, you have a crown that's just uniformly whitish. And if you want to make it look more natural for the anterior teeth, or cutting veneers or so forth, the dentist might have to be painting some stains on it, firing it again, and things like that. That gets a lot more complicated, and there are people that are trained to do really amazingly good aesthetics for dental restorations, and they're called laboratory technicians. Okay? Dentists aren't trained so much to do that. You can train yourself to be really good at that, especially if you're a cosmetic dentist and really take it seriously. If you just use the word cosmetic dentistry in order to advertise your practice, probably not taking it seriously. There are cosmetic dentists out there that are really good at it. Okay? And there are lab technicians out there that are amazingly good at making crowns that are so lifelike that it's just remarkable. As long as you did a prep that allowed them to use their full set of skills, then you're doing your job. Okay. So we have a lot of options that are available to us nowadays. Unfortunately, the more options we have, the more careless people get, seemingly, in terms of actually implementing those options. And they tend to apply those options to everybody across the board. Oh, I've got a CAD/CAM machine, so I'm going to do a CAD/CAM crown on everybody. Okay? And there's a good reason for doing that. When you have a CAD/CAM machine, how much are you spending every month on the lease? Maybe $3,000 or $4,000. How much do you save for every crown that you do on the CAD/CAM machine as opposed to sending it to the lab? Let's say $100. Well, that means you have to do 30 or 40 crowns every month on the CAD/CAM machine in order for it to pay for itself. You're not making any extra money. Okay, so the economics are a little bit tricky. Do you have an office that does 30 or 40 crowns a month? You may not. Okay, so those are decisions that you have to make. Anyway, the website talks about that kind of stuff too. But adhesive dentistry is what opened up this whole new world. When I started dentistry, adhesive dentistry had opened up the world of composites compared to amalgams. Now it's opened up the whole world of CAD/CAM machines and all ceramic crowns and lithium disilicates and zirconia crowns and everything like that. But we have to understand adhesion. We have to understand the actual chemistry that we should be using, and we have to understand what the limitations are to that chemistry and how well we have to isolate the tooth to actually allow that chemistry to do its job to the point where the patient is as well served as we can possibly do. Okay, so we'll talk more about crowns and so forth as we go through. We'll talk about gold crowns the next couple of days. We'll talk about ceramic crowns the next week. And, we'll be discussing more different aspects of some of the choices that are made. The bottom line is, for amalgam versus composite, we have a choice. For crowns, we have choices. And the patient should be involved in those choices. These days, the patient's not involved in those choices. That's where we're not really treating our patient well unless we educate them to the point where they are part of the decision-making process, especially when it comes to their personal family finances. Okay? If we're breaking their bank unnecessarily, then we're not behaving as a healthcare provider. Okay? Because healthcare isn't just a matter of their physiological function. It's a matter of can they function in life. And a lot of people, if we force them to get a new credit card so they can pay for that $1,500 CAD/CAM crown, then that might seriously impact their ability to function in life with their family. So I just encourage you to think about that a little bit beyond the actual restorations. Whew. Okay. So, fun subject. But again, I want you to think in much broader terms. You know, knowing how to do a prep on a typodont, that's one thing, okay? And that's great, that'll get you through the exam. When you get into dental school and start working on patients and you start to educate your patients, then you're going to see a whole new world. And if you listen to your patients well and you respond to their needs, you're going to know the kind of practice that you want to get when you finally set up the practice. Okay, any questions about anything at this point?
I just wanted to talk like, so when we do an amalgam prep for a class 2, so the isthmus width should be 1 to 1.5 mm.
Well, I say more than one anyway.
More than one. And composite can be about 0.8 to 1 mm. The isthmus.
Yeah, you know,
like just for the typodont. For
caries notwithstanding, yeah.
Yes.
That's all we really need to have as far as the typodont is concerned.
Okay.
That's kind of the ideal
prep.
the ideal minimum width.
Yes. And now, how far should the proximal box be from so the depth of the proximal box? How far should it be?
When you say, remember, depth is a very dangerous word.
Yes, that's so depth is like it can go like this as well. But how far back should it be from the axial wall?
Back?
As in deep.
Deep?
The distance.
Yeah, I want you to be just 100% clear. I know you have this question in your mind, but I'm going to insist that you make it really clear for me and everybody
How
else.
far should the proximal box width should be from the axial wall and from the adjacent tooth?
Okay, so you want to know how much distance there should
Distance.
be between the adjacent tooth surface and the axial wall?
Axial wall, yes, Tom.
I don't know. I've never measured that. You could measure it,
Yes.
okay? It can be measured. And so, you know, we'd have to measure it in a bunch of different circumstances. We don't typically measure that.
Okay.
But if you wanted to measure that, then you could put a number on it. Typically, we measure the width of the gingival floor
The gingival floor.
to get an idea where the axial wall is.
Okay.
Okay, that's what we typically measure. Okay. You could, however, measure the distance from the adjacent tooth to the axial wall and be more, and you might find that to even be useful. It's just that it's rarely used. Okay, but it could be. You might develop a whole system on your own to get an idea as to where the axial wall should be.
I see.
Okay.
Because whenever I make the axial wall, like Dr. Mahi was telling me, it's like it's too deep. Get it forward. So.
Well, when you make it at the first, you know, like I said, if when you drill your holes and cut away from those walls, keep the burr about 1 millimeter from the adjacent tooth to start with. That'll get you close. It's not going to be too deep. It's not going to be too close to the adjacent tooth. So that'll give you a good start, and then you can adjust it later by measuring. Once you get gingival clearance, you can measure the width of the gingival floor.
Yes, sir.
And then you can adjust the position of the axial wall to get the width, mesial distal width of the gingival floor that you want. Okay. So yeah, there's always some adjustment that we can do. You've seen me do that when I've been doing the preps and so forth too.
Yes, sir.
Okay. But you know, if the gingival floor should be 1.2 and it's 3,
Then it's a problem.
that's a big problem.
Big problem.
Yeah, that's a significant difference, isn't it? So if it's 1.2 or 1.3 or 1.4, not such a big problem, but once you get over 2 and the axial wall's like in the center of the tooth, it's right on the axis of the tooth, well, obviously you're in the pulp chamber. So that's a big problem. Okay, so we have to, again, it's looking in the right direction.
Yes.
As long as you see where it is when you're doing it, that's the main thing. measuring where it is after you've done it, and you couldn't see where it was when you were doing it, is a problem, okay? So you have to see where it is while you're doing it, and we can. Okay, by looking parallel to contact, downward at a 45-degree angle, so I see exactly where I am axially. I see how close I am to the adjacent tooth. Those are things we have to see, just make sure you do. And you can adjust it however you want a little bit later on, but you won't end up like over here.
Yes, sir.
If you start trying to look down the axis and you're leaning the burr like this and cutting along like that, and then you look back at it afterwards and you go, wow, that's really huge. If you go back and forth between the corners, instead of coming down one corner and cutting away from that wall, coming down this corner, cutting from that wall, if you go back and forth between the corners, it gets deeper and deeper. Okay.
It was 1, 2, 3.
When you start to move back and forth, things get more and more concave, don't they? Because you're cutting twice in the middle and only once at the edges. Okay? So a lot of times, and when you get exit angles that are really obtuse, it's really easy for the axial wall to just follow those facial lingual walls. So if they're closer to 90 degrees, then it's easier to make corners and get the axial perpendicular to those walls. But the more obtuse you get, the more the axial wall tends to go deeper and be concave in the wrong shape. So again, position, get your axial wall, get your exit angles the way you want, and to try to define corners. It's the corners are the key to the whole thing. When I first started teaching the courses in -- I had groups of students that were preparing for the California clinical exam, so we were practicing to get ready to work on patients. And I had just graduated from dental school at that point, so I ended up, every once in a while I'd say, oh, I don't like the shape of my axial wall, what's wrong? It's going this way. And I'm thinking I'm supposed to be teaching how to do this, and I don't like what I just did, okay? And then all of a sudden it occurred to me, all I have to do is focus on the corners. I was trying to shape the axial wall, and that's never going to work. But just make a nice position and a nice definition for the corners, the axial wall takes on its own shape. Once I figured that out, then I never had that problem again.
What kind of burr should we use for making those? I'm kind of having a problem when I'm making the box. One problem is overextending the box.
Understanding which direction?
More facially.
Okay.
And also, I'm pushing the box too much back, and because I'm trying to make the 90 degree, but it just isn't working. For me, it's easy to make a lingual. The facial side's always kind of struggle.
Overextended? Yeah. Well, okay. So what you have to learn, of course, is first when you find the margin. Okay, so you cut in the middle of the contact, you nip out a little bit at a time until you find the facial margin, and you stop when it's half a millimeter. You know it's going to be about half a millimeter from the adjacent tooth. From then on, all you do is start in that area and start cutting away from that margin, away from the adjacent tooth. That's all you're doing. You're never cutting toward it. You're never leaning the burr, toward that wall. You're keeping the burr vertical. You start at the margin. You always cut inward. So you see me do that dozens of times so far, and the margin never moves because you start cutting at the margin and you cut away from it. You're cutting deeper into the tooth. You're cutting more tooth structure. Now, if you are not focused on cutting straight in, if you end up pushing this way because you're looking in the wrong direction, you can't see which way you're cutting or which way you're pushing, then you're going to lose control pretty easily. If you're cutting from the inside out, you're always going to overextend. Okay? So that's why, when you discover that you have that problem in terms of overextending all the time, the way to solve that problem is to do it differently next time. You can't do it the same way and expect a different result, right? So try something different. Watch the videotape of how I did it or whatever, and then say, okay, I think I'll try it that way. Then you might discover, okay, now I've got the margin where I want it. Cut in, I got the angle the way I want. What's the problem? It's right where I want it, and you don't have to have any issues with that. Now, when you're going gingerly, as long as you keep the burr vertical, then that wall's going to stay where it is too. If you start leaning it into the wall, then that's when you start getting a big mess. And then you're leaning in, and the top part gets all curved, and then you have to move the margin out in order to get rid of the undermined enamel, and then it's compounding your errors. But again, if you look in the right way, cut in the right way, and make sure you check that the burr is vertical, you're guaranteed of a good result. Okay? But you do have to practice it. You do have to look at each aspect of it as you're doing it.
It is getting better, but...
Okay, well, we got time. We're not in a hurry. Yeah?
So, for the composite preparation, when we talk about our occlusal cavity walls, what should be their height? Does it have to be like a minimum of 1.5 just in case of amalgam, or it could be?
Okay, good point. For amalgam, we had a minimum height of 1.5, so that the shortest, the thinnest amount of amalgam at the margin was going to be 1.5. In other areas, the amalgam can be a lot taller, it's not a big thing, but as long as it's no less than 1.5 thickness of amalgam at a margin, we're good, right? Now, composite doesn't have to have a particular thickness. Sealants are very thin, and as long as they're adhesively bonded to the enamel, then they stay on just fine, and we're good. But in this case, we're not doing sealants, we're doing restorations where the pulpophore is going down into dentin, just into dentin, so that we can see the DEJ on the walls. We know we've removed the decay at the DEJ on the occlusal surface, okay? So that's the same pulpophore position for amalgam and composite.
So
All right.
just into DEJ.
Just into the DEJ. Okay, so here's the position over here. We put the pulpophore in the same position whether it's amalgam or composite. So for amalgam, the shortest wall is going to be 1.5 typically to get that pulpophore indented. So for composite, it's the same thing. The wall's in the same place, the same height, the pulpophore is in the same place.
So that's also 1.5.
Yeah, so the shortest wall is going to be 1.5.
Okay.
Yep.
Yeah.
Your hand went up a little bit like that.
So the facial and lingual like margin are really
On where?
facial and lingual clear.
On the boxes here? Huh?
Should we have like bevel there for composite or not?
Well, what would the bevel accomplish? What would the bevel do?
Again, like adhesion.
Yeah? So let's say we have a class 2 amalgam prep. So let's say we have a class 2 amalgam prep already, and we take out the amalgam, we want to replace it with composite. Okay? It might be the most conservative thing just to bevel like that. But if we're doing it from the beginning, just make an obtuse angle and we're fine. Don't need a bevel. Now, actually, I forgot to ask you guys an important question. I'm glad I remembered, so you reminded me. Thank you very much. So here's an important question. Okay? Has to do with these preps again. So we can look at this prep right here. Well, I'm offended by that undermined enamel, so we're going to get rid of that. So we know a little bit about how the composite prep should be done, and we were talking about bevels a minute ago, and that's kind of important. So I'm going to ask you a question, and I want you to be confident that you have the right answer. So here's what I want you to do. I want you to visualize. Visualization is very important in this course. I want you to visualize $1,000 cash. Can you do that? So picture 10 $100 bills. Picture them sitting right on your bench, on your table. Okay? And then I'm going to ask you a question. And if you get the answer right, then you can keep the money. If you get the answer wrong, you have to give the money to me. Okay? So it's worth $1,000 to get the answer right. Now we have all the information you need to get the answer correct. But probably the first thing when I ask you this question, the first thing that's going to occur to you is you will have heard somebody in the past give you the answer to this question, but assume it's wrong. Assume they were wrong. Okay? Assume you just don't know, and we have to figure it out right now. Okay? I don't want you answering just like this. I want you to figure it out so that you're 100% confident that you have the correct answer before you give it to me. Okay? Ready for the question? It has to do with bevels. So we talked about exit angles for the facial angle proximal walls. We talked about beveling the gingival. We talked about getting adhesion, the exit angles, cutting across the end of the enamel rods, all that kind of stuff. Should we bevel the occlusal cavo surface margin? Don't answer. Think about it. You might be best advised to actually take a piece of paper and draw a couple pictures. You could draw one picture that would give you the answer. Okay? So when we're trying to decide if we need a bevel here on the occlusal cable surface margin, what we're asking is it already adhesively bonded? Is the composite already adhesively bonded to those margins? If not, then we should probably bevel. If it is, then we don't need a bevel. So what do you have to figure out to know whether we already have good adhesive bonding at those margins? Draw a picture and you can figure it out. We know what it takes. Nobody seems to be rushing too fast to their piece of paper. There's a picture on the board already that is most of what you need to have to figure this out.
Dr. Could you repeat the question again?
Do we need to bevel the occlusal cable surface margins on a Class 2 composite prep? Would that help?
So where was the places that we have to have the bevel on the box?
Well, we could either bevel or flare the exit angle on the proximals. We bevel the gingival to get good adhesive bonding down there. Because if we don't bevel the gingival, we don't have good adhesive bonding. If we have a 90-degree exit angle, we don't have good adhesive bonding. So what we have now on the occlusal surface, the question is, do we already have good adhesive bonding or not? If not, then we might need to bevel. But we have to figure it out by making some drawings.
So gingival, we did bevel there.
That's the bevel for composite.
And what about the walls of the box?
That's what we just said. Instead of being 90 degrees, we flared them.
Yeah.
Yeah. But the occlusal margins, we haven't talked about. Now, if you're really good at three-dimensional visualization, if you've been really enjoying those problems in the workbook, 3D visualization, you can probably do this in your head. But if you haven't been enjoying those problems, it might be best to draw it out on a piece of paper. So which of the drawings on the board do you think would be the most helpful?
That bottom.
This one? Which one?
Both are pretty good.
Both are pretty good? I don't know.
Different angles.
The bottom.
Which one, this one?
Yes.
Ah, okay. Well, not, those aren't the most useful. So again, how do we know we're getting good adhesion? How do we know we can get a good adhesion? We have to see what's going on at the margins with respect to the direction of the enamel rods, right? That's how we get adhesion. That's what we were talking about earlier. So if we want to decide, okay, do we already have good adhesion at the occlusal cable surface margins? We have to draw the enamel rods to see if we do. And if we do, then we don't need to bevel. If we don't, then we need to bevel. So I have my yellow pen here. Yellow pen, that's my enamel pen. So I can draw some enamel rods on one of these pictures and help you make your decision, but does anybody have an answer? I don't have any money yet. I always get at least a couple of $1,000.
I have only doing answer. I don't know why.
What's that?
I think I reverse bevel. That's what I on the cable occlusal cable surface margins. We give a reverse bevel.
What's a reverse bevel?
It's something I remember second year.
A reverse bevel, I'm not sure what that is. So if we have something, if we have something like this, if we were to bevel it, it would look like this. I'm not sure what a reverse bevel would be. There are a lot of different kinds of bevels, and that sounds like a cool term. I just don't know what it means. But again, the name of something isn't as important as the actual physical picture as to what it is and why we're doing it.
So what about the like occlusal forces? If you bevel them, the occlusal forces displace the amalgam and the bevel.
We're talking about composite now.
Yeah.
Yeah, that's a good point, and we'll get back to that. Because it's another question, is that if we thought that we had to bevel the occlusal in order to get adhesion, what are the consequences of beveling the occlusal? You know, and we have to think about that too, and it looks like you already are, which is good. But let's just ask ourselves, do we already have good adhesive bonding at the occlusal taper surface margins? If you think we do, then we don't need the bevel. Okay. Sounds like you want to make a bevel though, right? Can I get you to commit? I just want the $1,000.
How much more do you want, Doc?
Can you help us draw the rods in the?
Oh, I'm about to. If you can't draw enamel rods, I'm about to do it for you. So you think we should bevel?
For me not.
No, huh?
Yes.
Okay, I got an answer. Positive? Worth $1,000 to you?
We could answer it in yes or no.
Huh?
Can we answer it in a yes or no? Without the explanation.
Oh, you don't need an explanation. I'll get money one way or the other, so. Yes or no?
Just a minute.
Yeah, that's the thing. I want you to be certain. You sound pretty certain. You don't sound certain at
We
all.
won't bevel it. Not the walls.
Well, we can't bevel walls, we could
Yeah.
bevel the margins.
Margins. No,
Okay, no.
the margins.
So now,
Oh, we round the margins.
what's a rounded margin?
I mean, we smoothen out the margins.
Smooth out.
Yes, like we don't.
Well, right now they're very well defined.
Hmm.
It's a nice smooth outline, but at the surface, they're well defined.
But the bevel of the.
Okay?
Oh yes, we would bevel it, Doc.
So there's a non-beveled occlusal cable surface margin.
Hmm.
So you think we should bevel it? Positive?
Positive.
You sound positive, but you do too. So, hey, either way, I got $1,000, right? Just depends on who I get it from. You're still not sure. Nobody else is committing. Okay, so let's draw the enamel rods.
I already drew. I just want.
All of a sudden, you must have an opinion.
I do, but I just don't know if my direction of the rods is.
Enamel rods are always perpendicular to the surface.
Oh, okay.
Always perpendicular to the surface, whether it's on the axial walls or whether it's on the occlusal surface. They're always perpendicular to the surface of the enamel. So what do you think?
So, like, whether we are looking at like mesiodistally, even then they will be perpendicular to the surface. In the second row, in the middle drawing.
Here?
Uh-huh.
Okay, that's a good drawing to look at.
Yeah.
So I should draw some enamel rods here, huh? So if the original surface is like this,
Uh-huh.
again, the enamel rods are always going to be perpendicular to the surface, right?
Okay.
Right?
Mm.
So then we do the prep, and the prep definitely exposes the end of the enamel rods.
Okay.
So we already have adhesion.
So we.
So we don't need a bevel.
Yeah.
Yes, that's my answer, that's my opinion.
Yeah. That's my direction of the rods, exactly like yours.
There we go.
So
Okay.
we don't need a
Perpendicular to
bevel.
the surface. So now we're good. But what if we do make a bevel? This is where it gets interesting. If we do make a bevel like this,
No.
first of all, the prep gets a lot bigger on the occlusal surface, so it's more subject to wear, which is a bad problem with composite. Because when we restore the tooth, it's going to be restored like this. And this area is pretty thin here, isn't it? Where the composite covers the bevel, it's pretty thin. In 6 months, it probably won't be any composite on those bevels anymore. So even if we had to make the bevel, it wouldn't be of any use. Not after 6 months or a year. But we don't need to. That's the good news. We've proved it because we drew the enamel rods and all those walls cut across the end of the enamel rods just fine. Is that clear to everybody?
There's no right answer. We can or we cannot.
Well, it is true that you can or you cannot. All right, so ready to transition back to something a little simpler? Sound like a good idea, huh? All right, so we're going to be talking about anterior preps, but direct restorations, and the class 3, of course, is the standard. So let's say you're assigned to do a class 3 prep on a typodont. What do you need to know?
What class 3 preparations are?
Yeah, what they are, okay. What's the purpose of a class 3 preparation?
To remove the proximal decay, like.
To remove the proximal decay.
Without.
So you kind of want to know where it is. So where is the proximal decay?
With the
Contact area, apical.
So we have to be really specific. So apical to the contact, at the contact, those things don't mean anything, right? So can you describe to me where you think the decay is in such detail that I could draw it precisely on the board?
Middle third.
of the
Contact area.
So right in here? Anybody ever see a class 3 lesion there?
Including inside the lingual.
Okay, that's class 4,
Yeah.
right? That usually has to do with, you know, either a lot of decay or decay plus a fracture, something like this.
It's usually a little bit incisally, but it's not involved in inside the lingual.
So the incisal portion of the contact area,
No.
Middle 1/3.
Middle third of the.
middle third? Actually, I've only seen a couple of lesions in the middle of the contact. I've only seen a couple. And each one of those was a tooth that somebody, an orthodontist, had stripped with a diamond strip and flattened it out so it fit in the arch. Okay? So, you know, my conclusion from that is when you strip the proximal surface of the tooth like that with a diamond strip, that you're making a situation where the decay is likely. So, but if you have normal contours and no damage to the surface and, you know, the original surface of the enamel, the decay is not going to be here. Okay? So I got kind of lucky because in the around 2006, 2005 or 2006, there were several years for the California board exam when it still existed. They were requiring that all my students do class 3 preparations and restorations on patients. And so I had my students, so I had hundreds of students every year, and they would each bring in many patients for me to look at that all had what they thought were class 3 lesions. That would be possible board cases. So I saw lots and lots and lots of class 3 lesions every year. And now, you know, all of those were radiographically evident, but if you have a radiographically evident radiolucency on a proximal surface, it's not necessarily decay. Okay, so if you have a radiolucency in the proximal area, and maybe even on both teeth, what else could it be?
Overlap.
Well, we're assuming we took a good x-ray. Okay.
Resorption?
Resorption is going to be internally, so it's going to show up in the pulp chamber, and that's not something that we're
Can be
seeing.
attrition.
Cervical burnout.
Attrition.
Attrition, okay, so describe the attrition.
No.
What causes the attrition?
Calculus.
What causes the attrition?
It's heavy occlusive forces.
Okay, and so,
Moreover than attrition, it can be erosion because, so like in the maxillary, let's say in the maxillary anteriors, the lingual surface erodes a lot more
why?
because of if there is GERD or if
Okay.
you're having anything
Or
like.
intentional GERD, right?
Yeah.
I mean, bulimia is not as popular as it used to be, I guess. Maybe it is. But, you know, bulimia is something that's going to cause lingual erosion.
Yeah.
But that's not going to give a radiolucency that looks like this. It's going to give a generalized darkness of the film. Likewise, facial erosion. What causes facial erosion?
We have a lot of citrus fruits. Like,
Lemons.
Yeah.
Lemons. Okay. So neither one of those applies in this case. So we have a specific area of radiolucency. So what about attrition? So we have the maxillary tooth coming down like this, and the mandibular tooth is hitting it like this,
Yeah.
and it makes a wear facet where they hit.
Yeah.
It makes a little step, and that step is probably going to be in the marginal ridge area, and it could be anywhere along here, incisal gingivae, depending upon the vertical overlap. But if it's down in this area, it may very well look like what we're expecting to see in terms of a carious lesion, but it's not. So I had quite a few students bring me in great-looking radiographs. I got to notice after a while those radiographs look subtly different from an actual carious lesion. The radiolucency looks subtly different, but I got to be able to look at them and say, okay, that's probably a wear facet as opposed to decay. So be careful about that. But when I saw so many lesions that were true lesions, I got a very profound sense as to where they're located. Now, the California board exam was wise. They had a requirement that the lesion had to touch the adjacent tooth. The lesion had to involve part of the contact. And most of the time it does, but only the gingival part of the contact. So the lesion typically is about this area right here. So it's going to involve just the gingival part of the contact and down into the gingival abrasure. So a lot like what we're used to for the class 2s, right? So for that class 2s, the lesion goes into the gingival abrasure. That's why you have to have 0.5 millimeter gingival clearance. And it really doesn't come very far up into the contact area on a class 2. But we have to come all the way down from the occlusal in order to get rid of it. Obviously we don't on the class 3. We just come in from the lingual. Now, how does the lesion, how far does it extend facial-lingually? Probably something like this. And on the facial, I'm going to draw it coming out here like this. So there's oftentimes some decalcification that we can see in the facial embrasure. So the lesion comes in, but there's a little decalcification that extends out into that embrasure a little bit. That decalcification might be white, it might be brown, but it's visible, you know, conversationally. So if you have a lesion that penetrates to the DEJ, probably it's going to be visible on the surface in the facial embrasure as well. Okay, so if that's the location of the lesion, then we have to figure out where to put the prep. So let me make a couple suggestions. Okay, so there's the lesion, that's the decay. So what if we put the prep here? Does that make sense?
No.
How about if we put the prep here? That doesn't make any sense either, does it? Okay, well, let's say that we do the prep like this. That doesn't make any sense. What if we make the prep like this? Okay. Now, why do I make those suggestions? Not so that you'll do them, because you're going to do them. I see this all the time. So what I see is a prep that makes no sense. If you picture the lesion where it is, why would you do a prep bigger than that? Your job is merely to remove the decay and to do a prep that's going to preserve tooth structure and allow the restoration to be done well. But you're certainly not going to be extending greatly beyond the lesion. Okay? We're not going to get anywhere near up here to the incisal edge. We're not doing a class 4. We're not going to get incisal clearance. It's just not going to happen. So the incisal margin is going to be touching the adjacent tooth. And that has some limitations that she'll talk about. Gingivaly, we just have to go gingivaly until we get past the decay. If you have half a millimeter clearance or a few tenths of a millimeter clearance, then we're fine. The lingual wall is going to come around like this. We're extending lingually just far enough so that we can get the burr into the prep and instrument the axial wall. From the incisal view, where this is the lingual and this is the facial, we're going to put our lingual margin over here just far enough in so that we can take a round burr and go into the prep. We're going to keep it indenting. We're going to come out facially, something like that. So we're going to make sure we go far enough facially so that we've gone through most of the decay. I'm deliberately leaving a little bit of decalcification on the facial surface. We'll figure out what to do with that in a minute. But we have to go far enough facially so that we've gotten through most of the decay. I see a lot of students do a prep where the facial wall is right here. Now, that of course makes no sense whatsoever. Okay? The facial wall is still in the lingual embrasure. So, they've removed just a little bit of decay, but they haven't even gotten to the middle of the decay yet. Certainly not have removed all the decay out toward the facial. So we have to go far enough facially, and that's where a lot of people fall down. Like on the class 2s, if you haven't gone gingerly those 7 steps 100 times by now, you're probably not confident in how to go gingerly and that you can do it without messing up the occlusal part of the prep. If you just haven't done it enough, you don't know how to do it. So we practice going gingerly 7 steps over and over and over until we get experience with it. Same thing here. We go facially, and we do that enough times so that we get some facial clearance, because if we don't have facial clearance, we haven't removed the decay. We haven't done our job. Okay? So we're going to practice that as well. Okay, so if we go facially far enough so that the facial margin is out in the facial embrasure, then from the lingual view, we'll see something like this. So the facial margin is going to come up like that. So notice that where the facial margin comes up, there's some clearance between the facial margin and the adjacent tooth, all the way up to the incisal. The facial gingival line angle will be here, and there's going to be an axial wall that's hiding, because if I'm looking from the lingual margin is here, and the axial wall is back inside. But I can see the clearance between the facial margin and the adjacent tooth right up here like this. If, on the other hand, we do the preparation so that the prep looks like this from the lingual, now the facial margin, as it approaches the incisal edge, loses its clearance. That means up in that area, we haven't extended far enough facially. That means we haven't removed the decay in that area. There's still going to be decay at that margin. Okay? So we're very careful to make sure that when we go facially, we go far enough so the facial margin has some clearance from the adjacent tooth all the way up to the incisal margin. You position the prep incisally and gingivally exactly where the lesion is. Okay? Now, on the class 2, when we did the class 2 composite prep, and we went gingivally, we noticed that if we go gingivally and get 0.25 millimeters clearance, there's still going to be some decay there, right? And how did we get rid of that last bit of decalcification at the gingival margin in that case?
Hand instruments,
Nope.
we use the burr,
And what do we do with the burr?
we angle it,
Bevel.
bevel it.
Bevel. Yeah. So remember, here's a horizontal shoulder. There's an angle. There's a bevel. Totally different things.
Yeah.
Done for different purposes. Okay, so we're going to bevel it. We beveled the gingival margin on the class 2, and that worked beautifully. It's a great way to get rid of the decalcification of the margin without having to extend anymore, and it gave us good adhesive bonding at the gingival margin, so that protected the restoration quite a bit more. In this case, we have gone facially out this far. I have just enough clearance facially. So I could make a bevel. And in fact, we probably need a bevel to get rid of that decalcification. So I'll probably make a bevel right like this, using the same burr that we used for the class 2. And now, of course, the cool thing is, just like for the class 2, it's a conservative way of getting rid of the last of the decalcification at the facial surface. It also exposes the end of the enamel rods, so we have good adhesive bonding at that margin. That's a really important margin for getting a good adhesive bond because it's aesthetic. Gingerly, it was important to get a good adhesive bond so we didn't get recurrent decay in that very susceptible area. Facially, if we don't get a good adhesive bond in this margin here, eventually it's going to have a yellow stain or brown stain showing up, and that's going to be visible conversationally with the patient's friends. They're not going to like that. Okay? So the aesthetics has a lot to do with the staining that might be taking place at the margin. That's going to be minimized by getting a good adhesive bond at the margin. We're not going to get a good adhesive bond at the margin unless we have exposed the end of the enamel rods at the margin, which we can do with a bevel. Now, there's another point about why we make the bevel. So in the facial part of a class 3, we actually have 3 really good reasons for making the bevel. One is it's a conservative way of removing the last of the facial decalcification. Secondly, exposed at the end of the enamel rod so we get good adhesive bonding and no staining. Thirdly,
Surface area?
surface area is a 10% thing.
To
Okay.
add strength, like
No?
Line of demarcation.
Okay, explain that.
aesthetics, so that it, like it is inconspicuous, like you don't see the margin of the restoration separate from the tooth.
That's what you're talking about?
Yeah.
Yeah. So if you don't bevel it, there's composite and there's enamel. A sudden change from one to the other. Now, if the composite matches the enamel perfectly in shade and transparency, then even though the margin suddenly changes from composite to enamel, it's not going to be visible. That'll be okay for about 20 years. After 20 years, the tooth has changed, the patient's gotten older, the enamel's gotten more transparent. Now the match between the composite and the enamel's not as good anymore, and now it's going to be obvious. So if we bevel it, the change from composite to enamel is now gradual. There's a gradient between the two. So it's a gradual change from composite to enamel. So even if they don't match perfectly at the beginning, it's not going to be as apparent. So if you don't get the shade or the transparency perfect at the beginning, it's not going to be as apparent. And later on, if things change even more, it still might not be as apparent. So we have 3 reasons for beveling that facial margin. Okay? It's the most conservative way of removing the last of the decalcification, making sure it's gone, making sure you get good adhesive bonding at the margin by exposing the end of the enamel rods, and it's an aesthetic value of making a gradual transition from the composite to the tooth. That's pretty cool. I have no idea, but the bottom line is we know why that bevel is really important. We're going to do a restoration that's going to last 25 years in the patient's mouth. We want to make sure that we do everything just the right way so that it's going to accomplish what we need it to accomplish. Okay, so in any event, we're going to use a round burr to do this. I usually start with a number 2, and then I go to a number 1 to define the details and the internal form a little bit better. Before we make the facial bevel, we're going to angle the facial wall outward like opening a door. It's going to be angled outward. It's going to be pretty much perpendicular to the surface of the tooth before we put the bevel on. We're not pushing the facial wall forward facially like this. We're doing it like this, so we don't undermine the enamel. If we just move the wall facially like this, then that's going to undermine all this enamel right there, and that's not such a good thing, as you know. Okay, so we're careful to make sure we get the facial angled outward before we put the bevel on. Now, when we do the prep, when we first do the prep with the burr, let's look at what we can do with just the burr. round burr is going to leave a hook on the incisal edge. It's going to leave a little hook on the gingival. And facially, it's going to be a hook on the facial. Again, the round burr doesn't go all the way to the margin, so it's going to leave a little hook. So we're familiar with that from the class 2s that we've done with 55 burr and so forth. So there's going to be a little hook of unsupported enamel on the facial, one on the incisal, one on the gingival. So we're going to use hand instruments to fix that. So we use a hand instrument that's designed to do a class 3. It's a Jeffrey hatchet. We use a gold foil instrument, which we just label gold foil, and there's a 13 and a 15. One's angled one way, the other one's angled the other way. So one end of the instrument will cut the hook off the incisal and make a nice flat wall right into the contact area like this. One instrument will cut the hook off the gingival and leave a nice flat wall angled gingially with a nice 90-degree angle there. The other, and then either side of it, we can scrape the facial wall and get rid of the hook. We're scraping it at an angle. It's built into the instrument. So we're scraping it at an angle to get the exit angle that we want and get rid of that hook. Now, so what we do is we use the burr, and the burr creates a little hook at that facial margin. And we scrape it off with a hand instrument, and then we check the clearance facially. And then if we don't have enough clearance, we put the burr back in, the round burr back in, and we cut that facial wall again a little bit more, closest we can to the margin. And again, it undermines the margin, it creates that hook again. Scrape it off, check the clearance. Use the burr, use the hand instrument, check the clearance. Use the burr, use the hand instrument, check the clearance until you get the clearance that you want with a nice straight wall, perpendicular to the surface. Okay? If we have the clearance uniform up in the incisal area, if we have clearance facially all the way up to the incisal, then we can bevel. As we bevel, we're going to bevel everything that we can. So on the lingual surface, there's 3 line angles that we're going to bevel. So I'm going to label them 1, 2, and 3. Now this bevel over here on the lingual surface here would be number 2, matching this 2 up here. And then when we bevel through the contact, gingival to the contact, we're going to bevel number 4, goes gingivally underneath the contact, sort of like the gingival bevel on a class 2 composite. We're beveling gingival to the contact, and then we're going to come up the facial wall with the bevel that comes all the way up that facial margin like this. That's 5. We're going to use the same burr, the ETF3, for making those bevels that we're used to from before. Okay, so basically we're using round burrs. I didn't draw the lesion over there. No, you had another drawing there. Again, the lesion always goes from the gingival border of the contact down into the gingival embrasure. Okay, so that's where the lesion is always located. We're going to position our preps in the area where we know the lesions are. We're going to use round burrs. We're going to extend to the axial wall. We're going to keep the burr coming in past the adjacent tooth. Don't come directly from the lingual, because then your margin's going to be way out here. You don't need to have a lingual margin way over here. You can get the burr into the tooth without extending too far lingually. That gives us enough access to get to the facial margin. We're going to use the number 2 burr, then we're going to use a number round burr. Define the internal line angles, go facially with the burr and the hand instrument, the burr, the hand instrument, until we get the clearance that we want with a nice facial wall angled outward. Good clearance all the way up to the incisal. When we have all of that, then we're basically ready to bevel everything that we can. We cannot bevel the incisal because it's touching the adjacent tooth. We'll bevel all the other 5 line angles, and then we're fine. So, these are pretty tiny. They go pretty fast. But again, tiny. Okay. If you make it this big, that's too big. If you position it down here, or up here, or this big, none of that makes any sense. I don't know if I've ever seen anybody make one that was too small. So why don't you try that? Try to make one that's too small. It'll probably be too big. Maybe it'll be just right. But again, it's the location that's really important. You have a typodont. You're doing a prep on a typodont tooth. It's just an exercise. But again, you need to consider that it's actually simulating a patient. So if you're going to simulate a prep on a patient, you got to simulate doing the prep where the decay is. You know, our job is to remove the decay. You have to know where the lesion would be on a patient, so you know where to mimic it on the typodont, put the prep in the appropriate place. Okay? And the prep has to meet all the requirements. If you have an incisal wall that's curved like this, probably it's going to be undermined enamel, incisal margin, that's it. Take a hand instrument, get rid of that hook. Now you got it. Okay, so anytime there's any undermined enamel, it's going to be a failing prep. So we use the instrument to make the hand instrument, the Jeffrey hatchet, to make sure we get the incisal, the gingival worked out, get the facial angled outward facially and get it nice and flat. Put the bevels on. If we have enough axial depth so we can get the Jeffrey hatchet in there in order to scrape the undermined hook off the facial, we're probably just fine axially. So, you know, the criteria aren't too challenging here, not compared to a class 2. But again, if you're not putting the prep where the decay was, that's the most common source of error.
Doctor, can you repeat the bevels, like 5 bevels, one gingivally, one facially, third is lingually, and the other 2, like,
Okay, well, I drew them on here, but
yeah.
1, 2, and 3 are all on the lingual surface of the tooth. You know, they're all on the lingual surface of the tooth over here. So there's an incisal part of the lingual surface. There's this part here, which is, again, closer to the center of the tooth. There's this part here, it's kind of gingivally. They're all on the lingual surface of the tooth.
Okay.
Okay, they're all on the marginal ridge and in that fossa. Okay, and then we go from that lingual surface underneath the contact gingivally all the way to the facial wall. That's 4. So we bevel gingivally under the contact. Again, that's like the gingival bevel on a class 2. Okay, all the way to the facial and then right up the facial. Okay, so 1, 2, 3, 4, 5.